Okay, a meconium happens. Fetal distress. If at any stage during your labour you get meconium, green, brown, thick, the baby's gone into fetal distress. Okay. You monitor the fetal heart rate. The fetal heart rate of a baby is between 110 to 160. If it goes below 110 without recovery, that baby's in a real bad way. Okay. Over 160, mum could be dehydrated. Give some fluids, get that baby's heart rate down, but be prepared for resuscitation at birth. Okay. Pain in labour. Again, I hear you have nothing. Alternative methods: heat, shower, and position. Paracetamol takes 20 minutes to 30 minutes to take effect. So if you're going to have a baby, it's not going to take effect. Okay. Your green whistle will work, and it is okay in pregnancy. Give them it to suck on it, distract them. It's not going to have a problem. Morphine, again, subcut. We use it in labour, but it takes 20 minutes to take effect. Subcut rather than IV, because we don't want it to cross that placenta. Why is they used judiciously? If you give it too early and at 20-minute stage you birth that baby's going to be flat. So you're going to have a flat baby on birth. So if you're getting close to birth, just let her birth. It is hard for you guys to watch someone in pain. Okay? You're used to, they're in pain, I can stop this. Labour, we have to keep going with the pains. Okay? Second stage of labour is pushing this baby out. It describes the time when the cervix is fully dilated to when the baby's born. Longer, stronger contractions, you have a break, which we want them to rest in. Increased pressure in the bottom, urge to open the bowels and do a poo. Desire to push, they get nausea and vomiting, and then as the baby stretches out, their vagina stretches to paper thin, and it's really, really painful. Pushing phase lasts, that's okay, pushing phase lasts about 1 to 2 hours for the first baby, but it can take, it says 30 to 60, but I've seen it done in about 10 minutes, okay? That's for ladies that know what they're doing. So your fifth baby. Next one, obstructed labour. So if you've got a problem at this stage, maternal positioning, what we need is to open that pelvis, get it, the bigger area, okay, put them on the hands and knees, change them, lying on the sides with their legs up. Bladder, you've got to think of the internal structures. What's going to stop that baby coming down? If you've got a full bladder, it's going to stop it coming down. Either get them to go to the toilet, stick a catheter in, empty the bladder, the baby will move down. Same as bowels. We used to do enemas before they had pregnancies, but now we don't do it. So if they're constipated, that will do it. So they will push feces out when they're pushing, because that is in the road of the baby. Pushing techniques, often the technique of pushing is like they need to push right down as though they're doing a poo when they're pushing a baby. Fetal monitoring, listen to the baby while they're pushing. It will drop, it's just the recovery after it, because the baby will push on the cord and you'll probably get some head compression. So the baby's heart rate will drop while it's in a contraction, but we wanted to know whether it's going to recover after it. Okay? Okay, now descent. This is what's happening when the internal rotation. So when it starts to come out, the baby comes out, you can see the head went nice alignment, and then once the baby's head comes out, it will automatically turn itself to the side. So the head comes out, and you'll see this. The baby will do that itself, okay? And then you can either assist or actually push it out. It drops the shoulder, you bring it down towards the bottom, and then bring up. So you can see the angle it has to come. So we pull towards the bottom and then up to the abdomen. There is a video, I don't know whether it will work. So just click on it once it comes up. Yeah. It only lasts for 50 seconds, but it shows that whole process. the baby rotates itself and brings itself out. So if you actually have a lady in labour, they will know what they're doing. They will do it themselves. It's just to help get them out. You might have to click twice here. Yeah. Okay, so now we birth this baby up onto the mum, skin to skin, keep it warm. Tactile stimulation might give it a rub. I'm not going to go any further than this because the girls are going to do neonatal resus after that. I hear you guys don't have Synto, so you have a physiological third stage. Don't worry about cutting that cord in a hurry. It's not the last of your hassles. Bring the baby up, make sure the baby's breathing, tactile stimulation. That cord can stay there. It can pulse and pulse and pulse, and that blood supply goes to the baby still. Okay. When it stops pulsing, clamp the cords. You actually have a delivery pack, I understand. Clamp the cord in 2 places, cut in the middle. Okay. If the baby is quite sick, we want a longer cord because the neonatal resus may often use an umbicath to get access into that baby. Okay. So longer cord, give them some length. We can always cut it off later. And we look at the ABGARs. You guys covering ABGARs? Nope. Okay. So we look at the respiration, the reflexes, the heart, the pulse, and the skin colour. It's a 0 to 2 score. 0 means there is nothing. 1 means that, like, the colour is often, it's okay. The colour is often a bit pale pink. At 1 minute, 1 minute is a long time, surprisingly enough. But yeah, not at 30 seconds because the colour won't come up. But 9 is often, you usually score a low for the colour. But if their heart's beating, good heartbeat, their pulses are there, the moving arms and legs, then we're happy with it. Okay? Okay, third stage, we're going to deliver this placenta. Actually, I keep losing delivery, and I'll explain later while we show it. Physiological management is all you've got, apparently. You poor guys. No Synto. Okay, we use Synto and try and bring it on quicker. So the mother can expel it. Okay, it can take 15 minutes to an hour, so do not panic. Okay, signs that it's going to separate is that you'll get a bit of a gush of blood, and it starts to drop on the placenta, and the cord starts to lengthen. That means it's releasing. Okay, so you can help it as it comes out, but if you help it, please put your hand on top of the uterus here, because we don't want a uterine inversion. If you tug on it too much, you can bring the uterus out first, okay? So we don't want that. If the placenta stays in situ and it doesn't come out, not a problem. It happens to us all the time in maternity, okay? But we have to medically manage that out. So don't panic if that's a problem, okay? And the last stage is after birth. For the next 4 hours, there is a chance of a secondary postpartum hemorrhage. Okay, we need you to, once you've birthed and the placenta's out, get the top of that fundus and rub. Okay, that's your only options because you don't have drugs. You need to get to the top of the fundus, which should be around the umbi, and dig in. You have to rub and rub and rub, and you feel like a cricket ball. It's literally like a cricket ball sitting in that. If it's not contracting, the bladder may be in the way. Again, catheter, get them to go to the toilet. Routine OBS, okay? Because postpartum hemorrhage is, we have a lot of them that go at the 2-hour mark, they start to lose again. That you could rub and get that nice cricket ball, and 15 minutes later it goes boggy again, okay? So postpartum hemorrhage is greater than 500 mils of blood, okay? A blood transfusion bag is about 300 mils. Your risk factors are anemia. All our women are anemic. Okay, they run around with a HB of 90 if they're lucky. History of postpartum, big babies, preeclampsia, lots of risk factors for 500 to 2,000. We often have 1,000 because of the anemia and because we induce labour. That's okay. Go to the next one. I don't know why it did that. So 4 T's, but for postpartum hemorrhage. Tone is that rubbing. Rub, 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 rub. All I can say for you is rub because you do not have drugs to deal with this, okay? We have Masics. I don't know, do you carry tranexamic acid? No, not even ICPs. Wow. Okay. big trauma one. Sorry. That started to be a new protocol for maternity. We started using tranexamic acid in bleeds. So rub up the fundus is basically all you've got. So tone is your 70% of your bleeds. If you can keep rubbing and keep that going, you're going to save. Okay. Trauma. Once they birth, they've cut the canal or they've torn. That's your trauma. Basically, you need to pack that and get into the hospital. Tissue is if the placenta has removed and part of it stayed in, then the blood supply will still be pulsing into that and pouring out. So if you've left products in, then it's going to thrombin. It's anticoagulants, 1%. So hopefully you'll know. Not much you can do about it. The only way you can do, and that seems the only one, is bimanual compression. You need to stick your fist right up, push on the uterus. If you've got a massive bleed, get your hand on the fundus and hold that there. Once you go in there like that, you have to stay. It's very much like our cord compressions. It's got to be stayed like that till you get to the hospital. Okay? That causes other risks because your hand's in there and infections. So we have to treat ladies like that. Shoulder dystocia at birth. You can see here, this is, instead of that rotation, that shoulder gets stuck behind that pelvis instead of that rotating. Okay. Big babies again. Maternal diabetes, previous shoulder dystocia, short stature. So if you've got a 5-foot lady and the husband's about 6 foot something, you're going to have possible. But 50% can occur without problems. Next one.
Do you see that very often?
Yes.
Oh, it is. Okay. Yeah.
We do get a fair bit of that. Spay over the baby's head to restitute. That's the biggest sign. So instead of having it comes out, it just doesn't go off to the side is an indication. Turtle sign. Turtle sign is that the baby's head is sucked back into the pelvis. Okay, so it'll come out and then all of a sudden, and the baby's head's like this, right? You can't get into it. It's time critical to get this baby out now. Okay, because it's going to start squashing the baby in the cord compression and the airflow is not going. There's things called Erb's palsy because what's happening, so I've got this baby and I don't know whether it'll do it, because its shoulder is stuck, the head is stuck, it's not going to do. So we're stretching all these muscles. So think of your neck going like that and all that muscle is being pulled because of the shoulder not getting part is that Erb's palsy. And often, fractured clavicle is the only way we can get it out. And it's not nice, you can hear the crack of the baby's shoulder to get it out. Okay, this is an acronym kind of thing that we use, no particular order. But did I put that? Go to the next one. Okay, yeah. McRoberts. McRoberts is the quickest and easiest way, and it will relieve probably at least 50 to 60%. Bring the lady's knees to the nipples, not out like that, knees to nipples, and you can see that it's from that to that opening. It opens the opening a lot further, so hopefully the baby can go. The other thing is you've got the baby on the outside. You can feel this. You can push on the shoulder. So if the baby's head's like this and the shoulder's behind, you can get air and push on the shoulder and hopefully dislodge it. Anything to reduce it. All fours, again, brings that baby back a little bit. And often it's just the movement of rolling over. It opens that pelvis and gets the head released. Internal manoeuvres are not part of your process, but it's a matter of getting your finger in, trying to move that baby round. So you can see, push that shoulder out of the way. If that doesn't work, we're pushing the other way. If you see us doing it, we'll be in there trying to manipulate a baby. So it's different manoeuvres that we can do. I know internal manoeuvres are not part of your protocol, but it's nice to know they're there if you can kind of have the issue. Okay? Breech presentation's your other one, bum first. That's where the bum comes before the head. Okay? Previous breech births, if the uterine's not normal or they've got a low-lying placenta, often they don't move around. Multiple pregnancies, one's often cephalic head first and one's often the other way around. Okay. Different types of breech, one with your knees and your bottom coming down. Footling breech is the feet come first. Frank breech is just straight bottom with your legs up. Okay. Yeah, no, that's okay. Go on. Assessment. Fetal heart is heard up here rather than down here. And again, the abdo-palp, if you've got a head that can shake up here, you know the farts are coming first. Allow the birth to go spontaneously. The policy is hands off the breech, basically. Let the mother, but bring the mother to the edge of the bed so you can use gravity. So if you're going down here, then gravity, because if you're lying on a bed, there's nothing for that baby to hang. Okay, the baby should come out. So it's a footling, so the feature birth. And if it comes out like that, you can get your hands and just bring it like that. Okay, just so it comes out in alignment. But then the baby will come out. You can get your hands up like this. The head is always the concern, even for us, because we've got this baby hanging out with the head still stuck in there. You can get your hands underneath. It's called the next thing. Morris, we call it Morris smelly feet because that's the only way we can do it, right? So you get your hand in underneath, support the baby on your thing, and bring your hand to the nose, and you can bring the head down and bring it round. Okay, they are scary things because the head's just sitting out the thing. Okay, lastly, and the worst possible case, cardiac arrest of the patient. Routine cardiac arrest, which you guys are all practicing, okay? Except we need the wedge underneath the right side to get the baby, to displace the autocaudal compression, anyhow, uterine, okay? Maternal hypertension, decreased maternal, the mum's higher risk of aspirating because the stomach is and the lungs are pushed up here. We're not going to expand our lungs as much, and the stomach is being pushed up here. Okay? 5-minute rule. That baby's got to be out within 5 minutes. Okay? If you can't save mum, you can get the baby out. And the next sty is incision, straight down the middle here. Sometimes at 4 minutes you're supposed to actually have made that decision. A minute to get it out, take the baby out, and sometimes taking that baby out can actually save mum. Okay, it's a horrible, horrible thing to do, but and it's messy. Okay, basically scalpel straight down, cut through the things, take the baby out, pull the placenta out, and continue CPR all the way through it. And I think, so basically, remember you have 2 passengers, so Mum and Bob. We've renewed the antenatal issues, given you some tools to respond to some complications. Birth in most cases is natural, and the woman's body knows how to respond. So don't panic, the baby will come. Lastly, babies, now that's my delivery. Babies are birthed, only pizzas are delivered. Okay.
Every mum?
The mums can choose to go a physiological third stage. Some mums choose a lotus birth, is where the placenta remains attached to that baby for 10 days.
Yeah.
Okay. So we don't. But Synto, obviously our women are high risk of bleeding, and 2 litres is not a unusual occurrence in our maternity. So any high risk we will always give Synto. And we give Synto drips as well. So once we give them that Synto and they still continue, we'll put a drip up with and pump through Synto so that it all contracts the uterus a lot more.
I have a question. If we did have someone that was in cardiac arrest, obviously can that C-section be performed in ED at Alice Springs?
Yeah.
Yeah. So we would just call through ED and be like,
They'll be shit.
you call someone, you call someone to meet us right now.
Yeah, it got a pregnant woman in cardiac arrest. Yeah.
Yeah.
Yeah, but remember it's at 4 to 5 seconds to get, 4 to 5 minutes to get that baby out.
Well, we can move quick, Carolyn. We can move very, very quick.
Especially when they're pregnant.
Yeah, they would probably ring up to maternity and get the.
Yeah, call someone.
Yeah.
From our perspective, you might be able to use the auto pulse as well to assist with doing a more high quality CPR.
Yeah, I wonder if the auto pulse has ever been used in
Pregnancy. I don't know.
because they would have to lay flat on their back, wouldn't they?
Oh, no, you could still left lateral tilt them on the
can
board.
you?
Yep.
Do you think that'd be enough?
Chest stage,
Yeah. Would you tilt
I've not used the auto.
Tilt the whole board.
Yeah.
Oh yeah, that makes
Yeah, because
sense.
if you tilt the board,
I
because
was-
you can lift that board
Yeah.
and it still does it
Yeah.
on the side.
Yep.
Carol, if it was greater than 5 minutes, would they just not even attempt it? Is it just like a blanket rule, or?
That's usually the thing, is because mum's been deprived of oxygen for that long, then the baby's going to start getting deprived of oxygen.
Is this-
So the other thing is if you're talking a 25-weeker, I wouldn't worry about
Yeah.
the baby. Often though they say that if you can get that baby out, it takes the pressure off the mum's system as well. So sometimes you can get mum back afterwards, after taking the baby out. But it's the worst possible case, really.
5 minutes with no interventions, like no CPR? So if they arrested on us,
Yep.
would that time be prolonged or not?
Not really. You've got to think of how hypoxic the mum's going to
Like
get.
5 minutes from arrest,
Yeah,
is that what we're
yeah,
sort of thinking? Yeah.
Yeah.
Anybody else got any questions? I had another question, but I can't remember, so I'll have to think of it another time.
I did tell, I have brought some placentas if you guys want to have a look at them. And
Yeah,
we'll do it at the end.
Yeah. Oh, actually, no, that's what I was going to say is Carol emailed me during the week and said, just getting stuff ready for the presentation. What do you guys have in terms of for your maternity jobs? And I was like, Great question, Carol. And I went through and I said, we have 2 blankets in our maternity kit. We have a bulb sucker. And she came in this morning, absolutely roasted me and was laughing. Was like, no, we're all right.
Yeah, we've got a bowl.
We've got a kidney dish, correct.
And the reason I thought that was because we have to keep Cinto cold, otherwise they're not effective. But we did go through a stage there. We had room temperature Cinto. So
We kept it room temperature in the UK.
Yeah.
That just it had an expiry date of 3 months, so they have to change it out every 3 months, not keeping it in the fridge.
Yeah.
And obviously,
We went through some stage that even in the maternity ward that we were putting Cinto in the cupboard. So I couldn't see why you guys.
because we
So
carry
you have
ergometrics as
Cinto
well.
on the plane as well?
Yeah. Because we don't have that time to get them back.
Yeah, I was going to say, like you guys can't just like.
and because we're all midwives on the plane.
Yes.
So we all have skills to use it. Yeah. So
It's always hard to judge the amount of blood. The 500 ml from postpartum, what percent roughly does it look like?
a kidney disc rule. It's really hard because you've got glycol mixed with the blood. So you'll have glycol, maybe a bit of MEC, mixed with the blood. So it's the hardest thing for midwives even to try and say how much blood loss is there.
Is it better to over or underestimate?
It's probably better to overestimate because at least what happens is if you have that blood loss anyhow, doesn't really matter for us in the thing. It gives us an estimate of how much they're going to lose. But in the maternity ward, what we do is the next day is take a HB.
Yeah.
Some of our ladies have had HBs of 60 after birth, so it's quite, they've only had 1 litre PPH, but they haven't got much reserves to play with the anemia. So.
Do you do routine like HBs in antenatal care to be able to do a comparison?
Yeah. They will get their HBs, and a lot of our women, if they've had antenatal care, get iron infusions before.
Yep.
Before they'll come in and get iron infusions. Probably about the 36-week mark, so we've got something to play with by the time they actually birth, because they're running around with HBs between 80 and 70 or 80 already before we actually start birthing them. So it is really hard to just. What we do is weigh it. So we get everything that we've used in the thing, and we go, okay, well, a big bluey takes 20 grams. A pad, so many soaked pads take 50 grams, and we sit it all on the scales and say, okay, well, it's got 5 blueys in it, so much, and take that away.
Okay.
But it still has one full ring, so it gives us some idea. Yeah, we just get everything we've got and weigh.
One more.
Yep.
Hang on, Tanya. Yeah, go.
Waters can break days before birth. At what point is that a concern, and should they come in?
18 hours.
Okay,
Yeah.
so longer than 18
So,
hours, or if they...
once you get to 18 hours, we need to start antibiotics on you. But we've had some people that have ruptured membranes, and we've started 3 days of antibiotics and then sent them home on orals.
Yeah.
So it doesn't mean you actually have to birth. It just it means we need to start watching that you've actually ruptured your membrane, so that chance of that baby.
So if
being
they have
exposed.
ruptured their membranes and they say to us, my waters are broken, do I need to come in?
Yep.
What's our...
I would say yes.
Yes, just bring them in.
Because you know what? Half the time they haven't ruptured their membranes, they've actually just wet themselves.
Yeah, they're cool. They're cool.
So we're actually trying to prove whether they've actually ruptured membranes, and we will do speculums. But basically what we do is leave them flat for about half an hour, open speculum. If they're pulled inside, then we know they've ruptured membranes. If they haven't, then they've probably just wet themselves. But it's felt like it's a ruptured membrane. So bring them in, because we would want to know that they have. And if they have, then we need to treat them. If they haven't, we'll just send them home. Again, we'll treat them with IV antibiotics probably 3 days, and then send them home for orals if they haven't gone into labour. But also at that time we start to induce them with steroids. So we want to develop the baby's lungs, because there's a good chance that they will birth sometime early, and we want those lungs to be developed so neonatal guys don't have too much work.
Okay, anything else? No. Thank you so much, Carol.